This patient was an African-American female in her early 30s. She initially presented to us with sudden onset left-sided chest pain. It was non-radiating and very focal in nature. Prior to this, she did have upper respiratory symptoms, which included a runny nose, nasal congestion, and a cough. She interestingly denied any dyspnea, no weight loss, no fatigue, fevers, night sweats. So on presentation to the emergency department, they ended up having a concern for a PE after an elevated D-dimer and LDH. Her other labs were rather unremarkable. So because of this concern for PE, they did a CTA of the chest. And while fortunately no PE was found, they did find a minimally displaced left posterolateral fifth rib fracture, as well as multiple other lytic lesions, notably in the bilateral scapula, the sternal ribs, and areas of cortical disruption in the right iliac bone. Because of these findings, she was admitted to the hospital for further workup. Initial workup in the hospital showed an SPEP with only hypogammaglobulinemia. A CT-guided bone biopsy was done of the lytic bone lesions. And subsequently, her urine immunofixation study resulted positive for kappa-type Bence-Jones protein. In addition, her serum free kappa light chain level was elevated, as well as the serum free lambda light chain with a high kappa lambda ratio. And the bone biopsy did result positive for kappa restricted plasma cell neoplasm, and showed greater than 95% total cellularity. She was unfortunately lost to follow-up for a few months. But ultimately, she did return for treatment of her now diagnosed multiple myeloma. She was ultimately treated with 4 cycles of daratumumab plus lenalidomide, bortezomib, and dexamethasone, which was followed by autologous stem cell transplant. Fortunately, after that, she was in and has been in complete remission. Challenges in diagnosing younger patients with multiple myeloma typically result because younger patients don't present with typical symptoms. Early signs of multiple myeloma include anemia, bone pain, elevated creatinine, generalized fatigue, hypercalcemia, weight loss, which our patient didn't really have any of these. The median age of diagnosis for multiple myeloma is 69 years old, with only about 1% of cases occurring in individuals under the age of 35, making her, our patient, extremely rare. And it is generally more commonly seen in men, so it's also not something that you would think of more in a female than a male. I think clinicians can learn a number of things from our patient, from this case report. As I said before, multiple myeloma is extremely rare in young patients and can have an atypical presentation that we're normally used to seeing. Just because a patient is presenting at a young age with some unusual lytic lesions should not automatically rule out the suspicion of multiple myeloma. And in fact, these patients can often present with bone lesions, including pathologic fractures, and that may be the only manifestation of multiple myeloma. Another challenge is that younger patients generally have, especially younger female patients, generally have many other life factors and unique challenges to consider, such as pregnancy, childcare responsibilities, career disruptions, and other life demands that may not be able to lend them to going to doctor's appointments as frequently as we think that they should. And younger patients typically have less advanced disease, which is fortunate. However, they still confront a higher mortality rate compared to the general population. And so considering an unusual diagnosis in a younger patient, whether it be multiple myeloma or other illnesses and diseases, should really always be in the back of our mind so that we can do the best for our patients.